بسم الله الرحمن الرحيم. Imaging of the biliary system. معاكم ناجي صلاح، درس الأشعة التشخيصية والتداخلية بالقصر العيني. Normal biliary anatomy. Right anterior, right posterior forming right hepatic, with the left hepatic forming common hepatic duct, with the cystic duct forming common bile duct, with the main pancreatic duct running at the ampulla of water at the second part of the duodenum. Other normal variant from right to left. First, where is direct insertion of both CBD and the main pancreatic duct into the second part of the duodenum. Second, low insertion of cystic duct at the lower CBD. Third, trifurcation, where is right anterior, right posterior, and left hepatic duct forming the common hepatic duct direct. And fourth, where is the right posterior duct insertion occur at the directly at the common hepatic duct. Imaging modalities of biliary system include ultrasound, duplex ultrasound, CT, cholecystography, radionuclide scanning, plain X-ray, MRI, MRCP, ERCP, PTC, operative cholangiography. Ultrasound, either transabdominal endoscopic elastography or duplex studies for diagnosis of stones, cholecystitis, focal or diffuse liver disease, elastography for hepatic fibrosis, duplex for hepatic vasculature. Ultrasonographic image from right to left show fatty liver, calcular gallbladder, portal vein thrombosis, liver cirrhosis and ascites, biliary obstruction, and biliary radical dilatation. Plain X-ray of the abdomen used for diagnosis of calcified lesions, as shown in these images from right to left, show pneumopilia along air along the biliary tree, porcelain gallbladder in second image, third multiple gallstones. CT with IV contrast accurate for identifying hepatic masses. Neither obesity nor intestinal gases obscure the CT image. The best for pancreatic lesions. CT images from right to left show cholecystitis with biliary dilatation, hepatic hydatid disease with focal biliary dilatation, hepatic cholangiocarcinoma with biliary stent, and lower CBD stone. Cholecystography, HIDA scan technetium taken by the liver and excreted in the bile, then enters the gallbladder. In case of acute cholecystitis, non-visualization of gallbladder is seen, rarely needed to diagnose acute cholecystitis. MRCP is more sensitive than CT or ultrasound in diagnosing CBD abnormalities, particularly stones, comparable with the ERCP and PTC, which are more invasive. MRCP is useful screening tool when biliary obstruction is suspected before therapeutic ERCP. MRCP is the screening test of choice for primary sclerosing cholangitis. MRCP images showing malignant biliary obstruction, hilar stricture caused by cholangiocarcinoma, multiple low signal stones at the CBD. ERCP, the papilla of water is cannulated and the contrast injected. Can be used to obtain tissue biopsy, accurate as endoscopic ultrasound for diagnosing of CBD stones. Because it invasive, ERCP is used more for treatment more than diagnosis. For the procedure of choice for treating biliary and pancreatic obstructing lesions, removal of bile duct stones, stenting of stricture, sphincterotomy. ERCP images showing from right to left detailed biliary anatomy. Second image show malignant biliary stricture at the lower CBD. Third images show multiple filling defects representing gallstones at the CBD. Percutaneous transhepatic cholangiography (BTC) with fluoroscopic or ultrasound guidance. Liver is punctured with a needle. Peripheral intrahepatic bile duct cannulated above the common hepatic duct. Contrast is injected, used as a therapeutic tool for decompression of biliary system and the insertion of drains or stent. Operative cholangiography contrast agent directly injected during the laparotomy to image the biliary tree. PTC images showing from right to left lower CBD structure, hilar structure, successful cannulation of the biliary system, successful stent insertion at the CBD. Last but not least, protocol for imaging of biliary system. starting by ultrasound as screening tool, dilated bile duct with bile duct stone ERCP, no cause found, suspected stone MRCP or MRI, suspected mass CT, endoscopic ultrasound or biopsy, suspected bile duct neoplasm MRI or MRCP, suspected infection ERCP or BTC for drainage, and tissue brushing. Thank you.